So it gives me great pleasure to introduce the final speaker of the morning, who is Daniel Dawes. He's a nationally recognized leader in the movement to advance health equity among under-resourced, vulnerable, and marginalized communities. An attorney, scholar, and health policy expert, Daniel Dawes brings a forward-thinking, inclusive, multidisciplinary approach to the law and public policy and has been at the forefront of recent major federal health policy negotiations in the United States, including being an instrumental figure in shaping the Mental Health Parity Act, the Genetic Information Non-Discrimination Act, the Americans with Disabilities Act Amendments Act, and the Affordable Care Act, also called Obamacare. He is the co-founder of the Health Equity Leadership and Exchange Network, called HELEN, which is a nationwide nonpartisan network of over 1,500 governmental and non-governmental leaders and scholars focused on bolstering leadership and the exchange of research, ideas, and information relative to the advancement of evidence-based health equity-related policies. Without further ado.
Good morning, everyone. Good morning. Thank you very much, Dr. Belcher, for that generous introduction. And I want to actually just sing her praises for a moment. She's one of those unsung heroes in our health equity movement who's really been pushing the boundaries, trying to elevate children's health equity. So why don't we give her an applause as well for all the leadership she's done. And I want to actually thank Dr. Schlager. I want to thank the Kennedy Krieger Institute for elevating the conversation around health equity and allowing me the opportunity to highlight this continuing struggle for health equity in America. So again, I want to thank all of you for the work that you've been doing to help push this movement forward, to actually help elevate health equity for all children and adults. And thought, I would start with a story. It reminded me of the time that we're in today where my brother, can you all hear me? Stand by the microphone.
Because we're broadcasting.
Oh, we are? Okay, all right, fine. So let me stay here then. All right, I like to walk around. But it reminded me of this time. My brother and I had actually visited a church one weekend. And my brother was really tired. So he's putting his head down on the pew. And I nudged him and I said, "Patrick, wake up. Wake up." He said, "Leave me alone." I said, "All right." And service is going. I said, "Patrick, wake up again." Not waking up. He's very irritated with me at this point. So I said, "You know what? All right, I'm going to leave you alone." And then the pastor comes up to the podium. And he said, thank you. He said, "Church, wake up. We've got to wake up." My brother was like, "Oh." He starts slowly looking. Oh my. I tell this story to say that in this era of post-truth, sometimes we all need a wake-up call to stay woke, right? So today I actually am very happy. I was pleased that Dr. Liu actually gave me this great segue into what I want to introduce. You've heard about the social determinants of health, right? Yes? Well, we're going to talk about the political determinants of health, all right? And I understand that you all have thick skin, so bear with me as we actually travel on this journey back about a few generations. I'd be curious. Actually, when we talk about the issue, Dr. Liu actually highlighted many of the disparities, right? Racial and ethnic, disability related. Talk about LGBTQ disparities. They run on and on and on. And every single year, we see numerous individuals dying as a result of these disparities. And we've been trying to tackle these issues socially as well as politically. We've made some headways, but every time we've made 2 steps forward, we tend to go 1 step back. And as Dr. Liu mentioned in his closing remarks, sometimes advocates lost the political will to prevent that pendulum from swinging too far that it causes tremendous damage. And it unravels a lot of the gains that we've made in this health equity movement. So I do think we are at this critical juncture here in the United States, one that will either take us forward to a more inclusive and equitable society, or if we are not careful right now, will take us backwards to a time of even more striking and alarming disparities among our most vulnerable. So here's just a partial listing. Obviously, you don't have enough time to go through everything. But right now, we have seen some challenges. And we've been working over the last 21 months to prevent the undoing of many of these gains that I was mentioning. So let's talk about this, right? We all know that health insurance coverage, Obamacare, has been under attack. We all know that depending on who you listen to, whether it is the Census Bureau showing about 100,000 individuals losing coverage that they gained as a result of the ACA, or you look at Gallup, they said 3.2 million since Trump took office, or Commonwealth Fund said it was about 4 million more uninsured individuals, right? During this period, I call this the fourth period in our nation's history when the light of health equity came. Office of Minority Health, we have been so challenged. Many of you know that back in the mid-'80s, there was an attempt to convene a group of folks to look at the striking racial and ethnic disparities in our country. Margaret Heckler, who was Secretary of Services, President Reagan, decided to convene this, and she was challenged by what she had seen. She says, while the overall health of the nation had been improving, the health of African Americans and other racial and ethnic minorities was alarming. And so they came up with this report. It actually included recommendations, and they established this Office of Minority Health at HHS. Now we are fighting to prevent its closure. Then we actually had to fight from the Trump administration, not only preventing its closure, but then merging it with the Office of Women's Health. He said that's unacceptable. There was a fight over the last few decades to also increase the authority under this office to give them grant-making and cooperative agreement authority. And unfortunately, that too has been under attack. Little pot of $16 million, but it's been a critical pot to help us develop programs across the United States to tackle these inequities in our system. Then we've been pushing back on proposals within from the administration regarding the National Institute of Health, where they say they want to reorganize institutes and centers and focus on highest priority research. Do you think health disparities falls in highest research priority? How many of you would say yes? Not one hand. You're right. Oh, no, it does not fall under highest priority research. In fact, it's the lowest priority research for many of these folks. And we've had to work with a bipartisan group of policymakers to say, wait a second, think carefully about this stuff. And you're going to see what we have been arguing to prevent this from happening. There's also been this major battle. Many of you know, you understand what strategic plans are, usually a 5-year plan to move the entity or the organization in the right direction. And every 5 years, we work to make sure that HHS includes robust health equity priorities, goals, etc. Well, under this administration, where we had references and a commitment to tackling the disparities among our most vulnerable folks, in this plan, I know many of you read the Washington Post article and other New York Times articles and so forth saying that CDC was being prevented from using the terms vulnerable or equity or minority, right? That's true. But in this strategic plan, there was actually a concerted effort to negate references to health equity, racial and ethnic disparities, LGBTQ disparities, disability disparities. They did leave it in the final draft. They had references to health disparities, but they would not define what that means to. Your guess is right? Then there was this refusal. Many of you who are champions of civil rights, you know that the ACA is not only a health law, a major health law, but it's also a major civil rights law. There were certain provisions that were intentionally included in there to protect patients, to protect clinicians and others. And in here, there's a section 1557. And this was our way to give folks a private right of action. Okay, that means that you're able to go to court and sue to enforce your rights. If you're a woman and you're discriminated against because of your sex, because you have reproductive age, right? That's no longer allowed by the insurance companies. You actually now have a right to sue to enforce that in a court of law. But no surprise here. There was an attack on it judicially. And we know that the administrative has not committed to enforcing this provision. We keep pushing back to say this is why it's important. A sixth piece that I wanted to highlight for you is this failure to collect and report racial and ethnicity data, right? ASPE, the Assistant Secretary for Planning and Evaluation, has been collecting this data. What we know is that many of these folks were terminated, many of them quit, they just couldn't take it anymore. And unfortunately, we know that the strategy has been all along, we've been struggling with this, and it's not just in this administration, but in previous administrations. If you don't have the data, or if we don't have the data, what does that mean? There's no problem, right? There's no problem. What do you mean there are disparities? So no problem, no data, no problem. That's been the idea, so that we don't have to allocate funding or resources to tackle those. So here are the arguments that we've over the last few years to get the Obama administration to prioritize the inclusion of this robust health equity agenda. We made essentially three arguments first. We made a moral argument, right? We said 83,000 racial and ethnic minorities are dying each year, and that figure was only for African Americans, only black folks. We didn't have the data for Latinos or Latinx. We didn't have the data for Asian Americans, Native Americans, other. We didn't have it for LGBTQ, and so we had to go with that, right? 83,000 folks were dying due to disparities. You know, this one segment of the population. We do know that it is quite a burden, a cost for the country. We didn't have the number, but thank God for scientists here at Johns Hopkins, researchers at Johns Hopkins University and George Washington University that actually did the research, calculated, and they came with this conservative number that every year we spend $300 billion on disparities in this country. So, where lawmakers said, oh, so sad, 80,000 people died. They said, after a while, you can only keep pushing, right? When the Tea Party was here, and folks said, what is it costing us then? Thank God for you all, we got the number, and we were able to stay at the table and push the agenda. Then, when things really started heating up again, folks said, okay, so it's costing us $300 billion. How can you prove to us that your provision, these health equity-related provisions that you're pushing, will actually reduce the cost, right? Luckily for us, in this country's history, whether it's law or policy, that national security argument always seems to trump the other arguments. And at that time, we had such a commitment to us. There were 600 admirals, retired admirals, and generals who worked with the Department of Defense to come up with a report. And in that report, it showed that 70%, 70% of young people between the ages of 17 and 24 were unfit for military service, right? Whether they had health issues, mental health issues, they were concerned about what they were seeing. We said, aha, well, we know that racial and ethnic minority children will outnumber white children in terms of births, right, in the next few years. That was the argument we were making back in 2009. And we said, so if you don't give a damn about the moral argument, you don't give a damn about the cost issue, well, perhaps for your own reasons, for your own security, you may want to care about it, right? So let's talk about this. We know that it's not an isolated issue with disparities. We've heard there are many multiple interconnected determinants of health. It impacts social and economic vitality of communities, because if people are sick and dying younger, they're unable to contribute to their community. And if that's the case, they're unable to outcompete our global competitors, and they're unable to defend this country. Well, thankfully, that resonated like it had generations prior, and we continue to have a seat at the table. So moving on, we made a fourth argument, right? That policy has been a driving force for many of the inequities that we've observed. At every stage of our life, policy actions or inactions through a complex web of political structures have been created at the federal, state, and local levels, and it impacts our health status, and it has been exacerbating the disparities among us. We said to folks, imagine this. Imagine how much richer this picture would be if we took a more expansive look at our complex ecosystem and gave each individual what they needed, each community what they needed, when they needed, in the amount that they need to reach their optimal level of health, right? Folks said, well, we take in limited resources. We said we could use these resources more effectively. Let's talk about this. If we are truly going to elevate the health of this nation, we got to have these talks. And oftentimes, what we argue is that we fail to appreciate and address the seen and unseen complex factors impacting health and wellness. So we talked about the social determinants of health. How about behavioral health determinants, genetics, and other issues, mental determinants of health, right? Why don't we dig down deeper and look at how there have been not only these interpersonal challenges or barriers, but there have been institutional, structural challenges that law and policy has created. And so we said girding all of those has been this idea of a political determinant of health. So I thought I'd bring us back now a few years. And I wanted to actually quote one of our greatest 20th century philosophers, Bob Marley. Any Bob Marley fans out here? Yay! All right, so in his song, No Woman, No Cry, he said, in this great future, you can't forget your past, right? We can't forget our past. So in order to understand the impact of the political determinants of health, let's revisit this past, right? Let's go back on this journey through our nation's history and recount the three periods in which the light of health equity dimmed in policy. When would you all guess was the first time in this country that the light of health equity dimmed in public policy? If anybody, any brave soul out there? Yes. World War II? Good guess. Anybody else? Nobody else has a guess? Huh? All right. Well, how many of you would say 1980? Raise your hand. Okay. All right. How many think it's earlier? Okay, we heard World War II. How many think it's earlier than World War II? Yeah? Okay. Yep. It certainly was. Usually I get folks who have heard about my book saying 150 years. And I give partial credit. I knew you were going to say that, Dr. Belcher. I give partial credit for that. Partial credit. But that's only half the story. It goes way back. So I want to take you all to 1750 when Benjamin Franklin. So anybody ever seen the musical Hamilton? I mean, yeah, good. I'm still waiting to see mine. So we're going to talk about another larger than life in the United States. Benjamin Franklin. Benny. So Benny actually said, you know, we've got to do something. And there was a physician who actually approached and said, you know, Benny, let's talk about creating a hospital here in Pennsylvania. And Benny says, okay, he wanted to create a hospital to help the indigent. And it was not just for those with click, but also for those who had mental health challenges, right? And so they went about thinking and strategizing. And Benjamin Franklin came up with a very, very clever political strategy to get Pennsylvania lawmakers to actually get the money. And after it was open, they allowed mental health patients with mental health, patients with ailments, and they actually were way ahead of their time. So integrated care, right, and behavioral health, primary care, they had been doing this for generations, and they were way ahead of their time because they did not discriminate against patients based on their race. So blacks and white, Native Americans were all allowed to come into this hospital until Jim Crow cleared ugly, right? So they got that done. Things were great. And then our great country was formed. So in 1789, when the first Congress, the first session of Congress convened, abolitionists working with Benny said, Benjamin Franklin, you have such incredible influence. Why don't you use your influence to help us make the case for abolishing slavery? And within that, help us make the case for advancing medical care, health care to these enslaved individuals, to people with illness, to those who were infirm, had disabilities, etc. And Benjamin Franklin, even though he was enslaved for most of his life, he actually was one that just never liked that institution. He thought that it was a really, and so he allowed them to use his name to push the agenda. And Ben Franklin agreed to put his name to a letter and plead with Congress, in that first Congress, plead with to please increase access to health care for these enslaved, for the most vulnerable among us. And you wouldn't believe what happened, or you probably will. There was a contentious negotiation in Congress. Oh my God, it flamed people. House and in the Senate. The letter was sent to the president of the Senate, who was the vice president at the time, John Adams. It was sent to the Speaker of the House. And both gentlemen were wondering what should we even address this letter that Benny sent us. Well, they decided to send it off to the committee jurisdiction. You guys debate them. And then as they debated, oh my goodness, you had these Southern politicians just didn't like the idea of eliminating or abolishing slavery. Then they came up with some novel arguments saying, well, that's for the states to decide. We don't want to touch this. And they were extremely concerned that as a new democracy, a new country, that, oh my gosh, we just can't afford to irritate these Southerners, right? George Washington was sensitive to the argument. Again, he didn't want to touch it. And unfortunately for Benjamin Franklin and the abolitionists and the mental health reformers and others who were pushing this agenda, they actually came back. So the House came back, and they responded. They said, oh, we don't do any of this stuff. And they responded a month before Benjamin Franklin died. So while he was eager to respond to pushing the agenda, unfortunately, he passed, and then that's when the first light started to begin, when they were trying to push the policy. Very sad, right? Then, they tried for how many decades after? 50, 60 years after now, they were trying to. We're going to keep pushing the federal government to not only abolish slavery, but to increase access to health services for the groups. The mental health reformers had tried back in the 1850s. And Dorothy, is anybody know Dorothea Dix? You ever heard that name before? All right, so Dorothea Dix was a school teacher from Massachusetts, and she had gone over to England, seen some of the reforms that they were implementing, and she came back, or went to Europe, came back, and she says, we've got to do right by our folks, because if you think today is a horrible time to live with substance disorder, imagine what it was back then, right? Many of these people were kicked out by their families, allowed to roam the streets, picked up, they were sent to jail, they were chained in jails, They were stripped naked. They were beat. It was a horrible, horrible time to live if you had a mental. And Dorothea Dix thought that this was a huge injustice. How dare we treat our most vulnerable groups like this? And she went around the nation, state to state, documenting the abuses against women. And she cleverly developed a political strategy as well to get Congress to wake up and to think about these and address them once and for all policy. Well, she finally succeeded in 1854 in getting the U.S. Congress to pass this comprehensive mental health reform, the bill for the benefit of the indigent and insane, right? But unfortunately, it always seems to be the president, who you would have thought would have been the first president to sign such a bill into law, he actually had experienced a very big tragedy in life when he and his wife, right before he was inaugurated as President, Franklin Pierce, and his wife was leaving the funeral on her side, coming by train, going home by train. And there was this tragic accident. The train veered off course, it crashed. The only person to have lost his life that day was their only son, their only child. And they witnessed his skull splitting open, blood everywhere. You can imagine how tragic it must have been, right? To witness the death of your child. And poor Mrs. Pierce was never the same again. She had clinical depression, anxiety for the rest of her life. She deteriorated. The president himself is deemed as one of the most ineffective presidents of our time. But he had the weight of this experience that kept bothering him. He became an alcoholic, a substance user. But instead of signing it, they thought for sure he would sign it, realizing from his own experience how critical the issue was. But instead of signing it, he vetoed it. And in one of the longest veto messages we'll ever read, he actually set the federal policy of inaction in human welfare issues for almost 100 years in this country. So we weren't even touching, piecemeal legislation about mental health reform, much less comprehensive, right? For almost 100 years. But I digress. Let me go back a few years after 1854 now, to the time when we're getting close to 1865. And these abolitionists were working with the Lincoln administration. They said, okay, once this works, we've got to enact legislation that will protect their rights, that will allow them access to clothing, that will give access to housing, so it's called shelter, clothing, transportation, security, etc. And there was an attempt again during this period, during that negotiation in Congress, to push the term health. We wanted to give them health care as well. And unfortunately, once they got it in, opponents succeeded in stripping that language out of the bill. They negated it. They would not allow it to pass as health. It's excluded. And so that bill is the one that I call the first bill addressing the social determinants of health in this country. Unfortunately, again, in this history, opponents who did not like the idea, even though this bill provided access to care, not only to former enslaved people, free people, but poor whites, who were called refugees, poor whites, who were displaced as a result of the Civil War. These opponents would rather cut off their nose to spite their face if it meant giving care to these free people. Horrible time. And after 7 years, they succeeded in dismantling the most comprehensive health reform law that this nation had ever seen before Obamacare. And we're going to talk about how striking similar Obamacare is. And you know this history. Is it any wonder then to see this really big battle over preserved Obamacare? So after that, Freedmen's Bureau, that was the second time in our nation's history in which the light and dim for a pretty long time, until you had Eisenhower, Kennedy, and Johnson coming in, pushing more piecemeal legislation around civil rights, around health care, ending the discrimination in our history. And then comes another president who worked to undo a lot of those gains that were done by not only Democratic Republicans. When Nixon came to power, he started eliminating funding for community health centers. He started eliminating programs that were intended to bolster civil rights. He refused to meet with members of the Congressional Black Caucus. I don't know if any of you were around the time, 1971, when there was a heated discussion. Their Black Caucus, because of the Voting Rights Act, had now 13 members, and he would not allow them to meet. He would not actually open the door to them. And they decided, during his State of the Union address, that they were going to turn their backs to him and walk out, right? It was a huge public relations win for the Black Caucus. We finally decided, okay, I'll hear what you have to say. And the best that they could do during that time, many of those programs were wiped out, but they got the AHEC and the HCOP program authorized. Anybody know what those are? HCOP, the Health Careers Opportunities Program. Any of you beneficiaries? No, it's to expose to the health. And area health extension centers, another vital program for exposing young people to clinical profession. So anyway, that's what they got through. That's when the third fight came in our country. Let's go more recently now, right? You heard me talk about Margaret Heckler, and it was the result of folks, researchers and scholars, who came together and they did their own report on the disparity racial in our country in the late 70s. Because the government didn't fund it. They couldn't get anyone to push government agencies to address the issue. They were scared to talk about racial minority issues. And so with these incredible people, Dr. Lewis Sullivan, who became Secretary of Health under Bush, W. Bush, David Satcher became 16th U.S. Surgeon General under President Clinton, and also George W. Bush, and others. We're going to actually tackle this issue once and for all, policy. So here's, I want to take now about 30 years. So healthy people. Any of you familiar with Healthy People, the Healthy People agenda in our country? Some of you, some not. So this is our nation's set goals for the next 10 years. And what they did in 1990, so it's a 10-year agenda. And back in 1990, they created this Healthy People 2000 agenda. And Secretary Sullivan says, I'm going to include as one of our metrics, reducing health disparities. And folks said, Lou, don't do it. His own advisors say, don't do it. It's too contentious. Leave it alone. Don't do it. And even folks at the White House said to him, God, you're putting President Bush in a precarious position by putting that in. He says, no, it's the right thing to do because it's truly going to elevate the health of the nation. We have got to tackle disparities. At the same time, Lou actually worked on a disadvantaged minority health improvement act with Senator Ted Kennedy. So Louis Stokes was one of the founders of the Congressional Black Caucus. Senator Ted Kennedy, who was chair of the Health Committee at the time, they got together, they built a relationship. And they said, you know what? We've got to preserve or codify into law what the Reagan administration had done in terms of that task force, right? Because they were scared that if they didn't codify into law, it'd be too easy for another administration to dismantle it, right? So they went about negotiating, finally got the first minority health-related bill, which also elevates the health status of poor whites as well. So it's not just a racial ethnic minority, but it was one that was intended to raise lower socioeconomic status individuals, right? And it actually provided the first investment from the federal government, $1 billion, to study health disparities. Well, 10 years later, Thatcher comes in with Donna Shalala, the Secretary of Shalala in the Clinton administration, and they said, this is very bold that you want to reduce health disparity, but what you have essentially done is to create a separate accounting system, create separate equal standards based on your race or ethnicity. So, let's take, for instance, the black infant mortality, right? Let's say, I think it's about 11.6 something percent now. And then white infant mortality rate was about 4 point something percent, or is. Let's say you that by 2%, right? Now we're down to 2 point something for whites, 9 point something for blacks, and then of course we did that for other racial. Well, that didn't that very easy with Sasser. They thought we should eliminate that, getting rid of such things. And so they then pushed this agenda and included the language that eliminate health disparities. And then they also worked Congress on this Minority Health Disparities Research and Education Act. And the Clinton administration said, not to be outdone by the Bush administration, let's increase the investments in this arena. And out of those two administrations came 6,000 peer-reviewed journal articles that were looking at disparities in all this, right? And we were then able to take that for those studies and use it to actually inform Health Equal 2020 and the Patient Protection and Affordable Care Act. So the Obama administration, under Regina Benjamin, who was the 18th Surgeon General, said, you know what, I like what you did in terms of focusing on eliminating health disparities, but we're going to be really bold. We're going to say achieve in the next 10 years. Well, we're almost at 2020, so unfortunately we won't reach that. But have you all noticed something in the timeline in terms of when bills were passed into law? Say it. Did you notice it? Or? All right. So notice 1990, 2000, we've had three major laws advancing this health equity. By my calculation, that should be 2020. So if we're on that track, keep your eye on 2020. All right. Let me take you now to a more immediate time in the advocacy for health equity. So back in 2008, we had three folks speaking. In the campaigns, we had McCain, we had Obama, and we approached all three campaigns and said, what are you all going to do to push reform agenda? And all three campaigns said, oh yeah, we're going to touch it. And at that point, I was on the Senate Health Committee, right? Working on the Mental Health Parity Act, the limited insurance reform statute to provide parity between mental health or behavioral health benefits and medical surgery, right? But we only said if you employer, you offer it, it has to be on par. We never mandate the benefits, never mandate the benefits. We wanted so bad an opportunity to make that essential for people who were still being discriminated in our system and unable to access behavioral health services. So we worked with all three. They told us that we said, what are you going to do to prioritize health equity in your health reform proposal? Well, McCain said, yeah. Hillary Clinton said, yeah. Well, Barack Obama's campaign was the only campaign that would explicitly include it in their platform. And they became the first presidential campaign to explicitly embrace this health equity agenda. And actually, so we were quite pleased. Now, as we were working on pushing this agenda, there was an effort to bring together groups that hadn't traditionally learned before. So we had the faith represented Catholic, Protestant, Jewish, Baha'i, Muslim, etc. We had the LGBT rights, or human rights campaign, and others coming together. We had the racial women's groups, veterans groups, disability, you name it. Likely bedfellows saying, you know what, we want to come together and under this North Star of health equity, we're going to push for a reform that actually prioritizes health equity. So together, this is a partial list of some of the groups that we work with. If any of you are a part of them, I urge you to continue your support. of them. They were extremely bold. They said, yes, we're going to put our influence, our weight behind this effort. We're going to keep pushing. And today, we have the Patient Protection and Affordable Care Act. And if you don't remember two things, I hope you'll remember these two. It is the most comprehensive law addressing health issues, not just racial and ethnic minorities, but people with disability, older adults, veterans, you name it. It is the most inclusive law ever produced and passed by the federal government. And I was quite surprised when I had made that case. I spoke to Congressman John Lewis, Ambassador Andrew Young, who many of you I recall was an aide to Martin Luther King Jr. and others, and I said, wouldn't you agree with me when you look at the look at civil rights? This is an even more inclusive law in terms of its content, and because of the fact that people or groups that don't necessarily wield power and privilege were invited to the table to craft it. So various communities were able to come in using their lens to help develop a law that would positively benefit their community. And every single one of those leaders in the civil rights movement said, yes, they agree with me. If any of you disagree, I'd love to reply. I don't think it's the most inclusive. But the White House was very scared when I was going out and pushing that notion. Lay low on that. You guys are just pushing too much. I don't know if that's what we really want to highlight. I said, why? That's a positive thing, you would think. And then, Dr. You mentioned, 16 November happens, and we're all like, wow, okay, I get it, Obama administration. I see it. Unfortunate. So we actually succeeded at getting 62 provisions in the affordable care. We were intentional about not just having a title around health equity, because we were concerned that opponents of this effort would try to jeopardize, undermine our advocacy. And so we put language in the expanded coverage provisions of this or type of this. We did the same thing when it came to data collection reporting section, prevention, wellness, comparative effectiveness. Any of you engaged in CER? Nobody is engaged in CER? Okay. So why is this for us? There were a lot of folks pushing for comparative effectiveness research where you're looking at two drugs to see the effectiveness of certain groups. Same thing with medical devices. And at the time, when we were negotiating this bill, we found that many women who are they have a disability were not able to access the medical equipment, the mammography machine, to get breast cancer, for instance, right? We wanted more to increase the accessibility of medical devices, medical equipment. But what we also was that while there was no real disparity among women, black, white, and Asian, etc., in terms of there was a huge disparity in death. Come to find out, black women were dying disproportionately as a result of breast cancer. Why? Because they have negative breast cancer, the deadliest form of breast cancer. And oftentimes what happens is these mammography machines do not include in clinical trials these women. And so they were created, these machines that could not be integrated. Oftentimes black women had to have cancer tissue. They could not integrate and find cancerous tissue. So there you go, two women leave the hospital, etc. Not realizing, no, you're actually not okay. And we wanted to do more to make sure that the discoveries that are created in a lab, community, that they translate into all, right? They positively benefit everyone. So that's why we were pushing. Same thing with delivery and system. Again, we wanted to make sure that if you are pushing to increase the quality, better outcomes, that you understand in this country, oftentimes that has led to an exacerbation of the disparities among racial and ethnic groups. So in the Northeast and Midwest, they tend to have the highest quality scores, right? In the South, we tend to have the lowest quality scores. But in terms of health care, we actually have lesser health care disparities than our northern and Midwestern neighbors. Isn't that it? So the fear was, you are pushing these delivery and payment system reforms. We want to make sure that you are taking an equity lens to develop these so that all communities can actually realize that they can enjoy the higher quality of care moving forward. There's another piece I wanted to quickly highlight for you all. So many of you remember on the day that the Affordable Care Act was signed, there was President Obama and Vice President Biden, right? Y'all remember that? And Biden whispered into Obama's ears, and the microphone caught him. Y'all remember that? And what did he say? Who was brave enough to recount that? Big expletive deal. That's right. Big expletive deal. And I actually argue, I think it's an even bigger deal than they probably even realized, right? But it's a really big expletive deal, even for this point right here, where we're improving access to health care, these policies, mandating essential health benefits, like I talked about. So we talk about behavioral health. Oh my God, I can't tell you how many times I've had people screaming at me as we've gone state to state, helping folks understand what this law is about. Saying, why do I need to pay for mental health coverage? I don't need it. And in fact, 1 out of 2 of my life will have mental health issues, right? 350,000 people are dying each year because of mental health issues. Well, did I get attacked for the maternity health piece? You know how many men have said, why the hell am I paying for maternity health coverage? Why is that an essential health benefit? I need flexibility in my benefits. What would you all say to that? What's that? Ask your mom. Oh, I like that answer. Okay, I'm going to have to borrow that one. That's a great. Ask your mom. That's right. And the reason why that was included was the National Women's Law Center actually conducted a study and recognized that women in the individual market, 90%, it's 90% of women in the individual market who thought health insurance coverage for health realized they didn't have it when it was too late. They got they needed it. And what was happening was many women were being accruing huge debt in medical expenses due to their delivery, right? So that's why that was with rehabilitative and habilitative coverage, those are perhaps the most contentious now. So any of you work with disability groups? Yes? Good. All right, I love this idea. So focus on this piece, the rehabilitative, our veterans, we're pushing to make rehabilitative coverage essential health. But our disability group have been pushing for habilitative. Anybody know what that one is? Anybody know what habilitative coverage? So rehabilitative is helping you gain something you may have lost, right? Some function. Habilitative is helping you gain something that you may not have been born with, right? A little more. And the Supreme Court back in 1982 had wrestled with habilitative. They wanted to find limited right for people with disabilities, children especially, but they couldn't get their arms. There just wasn't enough research. Well, back during the ACA, 2009, negotiated stuff, the disability community said, enough is enough. We want habilitative coverage. It's essential. Today, that is under serious attack in this argument for flexibility and benefits. So keep your eyes peeled on that. We talked about some of the 62 provisions that are in the ACA here. Just a partial listing because I have limited time until 5 minutes. I can't go into this, but if you want more information, I'm happy to discuss that. Again, the idea was to make sure that we were pushing this idea of cultural competence. We wanted to make sure those who were getting health insurance coverage, Obamacare, many of these individuals for generations, their family had no coverage. Many of these groups didn't even know how to use this coverage. Many population that health insurance was like auto insurance. If you use it, you get penalized, right? Or homeowners insurance. You use it, you get penalized. We've been pushing to take advantage of the preventive. So very interesting experiences there. There were also 7 national strategy. We wanted to make sure that the law required HHS to develop national strategy. So if you're in the quality improvement space, or if you're in the public health and prevention space, or the health literacy space, or the health IT space, or HIV and AIDS, or Medicare space, we wanted to make sure that these folks were taking an equity to their work and holding themselves accountable when it comes to the issue. Now, as I'm wrapping up, I do believe that we are marching towards health equity. I do. And I am actually impressed by the push I thought for sure that when Trump committed to shredding, that he may have succeeded based on what history had shown. Where both advocates lost the political will and energy to keep pushing to eliminate or unwind those health equity wins in the past, right? But I do think, even though we are going towards that, it's intensifying. And I wanted to leave you with this quote from Chief Justice John Roberts. So in both of the major Supreme Court cases involving the Affordable Care Act, with the individual mandate, subsidies, Chief Justice Roberts said, members of this court are vested with the authority to interpret the law. We possess neither the prerogative, the expertise rather, nor the prerogative to make policy judgments. Those decisions are entrusted to our nation's elected leaders who can be thrown out of office if the people disagree with them. It is not our job to protect the people from the consequences of their political choices. What did that do? So it limited opportunities for opponents to use the judicial branch, right, to push their agenda and push this back into the legislative arena. And so it's become the de facto battleground or battlefield when it comes to this health equity agenda. So I wanted to close with a story. Any of you remember President Carter? No? President Carter's wife, Mrs. Carter, Rosalind Carter, was a huge children's mental health champion. Many of you probably know. And back in November of 2008, she called a group of us, living there at the time, to come down to Atlanta to the Carter Center. And she had this sense of urgency about her that I didn't quite appreciate. I didn't understand. I said, Obama's been elected. He says he's going to push health reform. So we're good. She said, no. We've got to make sure that we are developing a strategy. We're coming up with a plan to bolster children's mental health. Prioritize this within any health reform negotiations taking place. So when she invited us to Atlanta, she also invited Marian Wright Edelman, president of the founder and president of Children's Fund, right? And this Ms. Edelman actually said something that has lasted. Actually, I thought was even more relevant today. She says that a president or Congress is only going to be as good as the citizens outside demanding it. That was when Obama became president, right? They were, I think, aligned in terms of outcome. Yet they felt that way. Imagine how much more so that is today with this administration. Keep that in. Thank you all so much. I appreciate it. Do we have the time to take one question or two? Any questions? Any questions? Yes, ma'am. Yes. Yes. Wonderful. Oh my God. Said it better. Yes. Well said. Thank you, Doc. Appreciate that. Because I do agree with you. Voting is that first phase of the political determinants, right? And not voting could be the matter or the difference between life and death. So thanks again. Oh, there is another. Okay. Yes, ma'am. Oh, great question. Yes. So, during the negotiations, opponents of this effort actually were outspending us 7-1. And they're putting forth all that fake news about the ACA. And then after the law, so right after the law passed, March 23, 2010, now there was this effort where they were pouncing. You had the Koch brothers, you had others, who were actually outspending us 15-1 at that point to, again, vilify the law. I think that's a part of it. Messaging. And then I think we actually we don't know how to speak in sound bites and how to create message that will resonate with the masses. We get all complicated about stuff because we're anticipating, oh, well, this and that. I think that's another problem. So anyway, 2 cents. Thank you for that question. All right. We're good? Well said. Thank you, Dr. Stone. All right.
So I want to thank everyone for coming to the morning session. As I said, you should have information on your afternoon session. Your lunch should be available if you're in the resident trainee scholar section in Finestone Hall. You should be waiting for you there. And I guess our lunches would be either in Phipps or outside. We'll be in Phipps, 140. I'll check outside. Sure. Okay. Thank you very much. And we reconvene at 12:30 for the next sessions.